Hello dear friends, how are you doing today? I hope you are doing well. Let's evaluate another question about dermatology. A 78-year-old woman presents with a purely healing area of skin on her ankle. She has a history of deep vein thrombosis 20 years ago following a hip replacement. She currently takes Atcal D3 and no other medications. On examination, there is a shallow ulcer anterior to the medial malleolus. She is otherwise very well. What investigation would be most useful in determining further management? A. Serum calcium. B. Ankle brachial pressure index. C. CT venogram. D. C-reactive protein. And E. Lower limb Doppler. Okay, here we have a 78-year-old woman with a history of DVT or deep venous thrombosis of 20 years due to a hip replacement, coming with a complaint of purely healing area of skin on her ankle. The patient is currently taking Atcal D3, which is a calcium plus vitamin D supplements, and there is no other medications. On examination, we can see a shallow ulcer anterior to the medial malleolus. She's otherwise very well. There is no any significant illness, systemic illness. And the answer is asking about the investigation, which would be most useful in determining further management. And the answer here is ankle brachial pressure index. Because of the history of the DVT of the patient, ankle brachial pressure index is important. Okay, explanation. This patient has the classic appearances of a venous ulcer. She is systemically well with no evidence to suggest infection. The most appropriate management of venous ulcers is with compression dressing. However, it is important to make sure the patient's arterial supply is good enough to allow some compression. And for this, ankle brachial pressure index is important. Venous ulceration. A venous ulcer, also called stasis ulcer or varicose ulcer, is a chronic skin ulcer that develops due to a chronic venous insufficiency or CVI, usually on the lower leg. It is the most common type of leg ulcer, equal to 70 to 80% of cases. Cause, pathophysiology of venous ulcerations: chronic venous hypertension from a well incompetence or venous obstruction, which leads to blood pooling and instantly leads to edema, leakage of proteins and red cells into tissue, leads to inflammation and fibrosis, and poor oxygen and nutrient delivery leads to skin breakdown and ulceration. As we can see in our patients, we can see skin breakdown and ulceration in their medial malleolus, which is the common site of venous ulcerations. Risk factors: varicose veins, deep vein thrombosis or DVT history, which we can see in our patient. She has the DVT history. Obesity, immobility or prolonged standing, and increasing age and pregnancy, all are the risk factors for venous ulcerations. Clinical features: the site of the lesion, most common around medial malleolus or medial ankle, as we said. Shape, usually shallow and irregular edge. Base or ulcer, granulation, tissue or exudative, or the lesions are wide. Pain, mild to moderate, which was if infected. Surrounding skin shows lipodermatosclerosis, which are hard, fibrotic, or inverted champagne bottle leg. We can see hyperpigmentation or due to the hemosiderin deposition. Venous eczema. We can see red and scaly patches. Edema and varicose veins are all clinical features of venous ulcerations. As we can see here, we can see hyperpigmentation, edema, and hyperpigmentation of the lesions of the patient with the diagnosis of venous Venous ulcers, here we can see the dry skin and hyperpigmentation on the medial malleolus above and around the medial malleolus of this patient. Here also we can see scaling, the dryness, scaling and hyperpigmentation of the skin of the patient's skin with the diagnosis of venous ulceration. Here also we can see the venous ulceration of medial malleolus. Here we can see also hyperpigmentation, scaling and the dryness of the skin. As we said, we can see the increase of the venous in this diagram. We can see the insufficiency of the venous walls and the enlargement of veins which leads to ulceration of the patient. Differentiation from other ulcers. Arterial ulcers are usually painful and punch out on toes or pressure points which are pale and cold, like the patient has usually pale and cold leg. And neuropathic ulcers usually are painless and usually are on pressure points like sole and heel and are associated with diabetes. Complications of venous ulceration: secondary bacterial infection, cellulitis, osteomyelitis can be present in a malignant change which is called Marjolin ulcer, which leads to squamous cell carcinoma, but it's very rare. Osteomyelitis also is rare. Management of venous ulceration. General principles: treat underlying venous hypertension and promote healing and prevent recurrence. Treatment steps: compression therapy is mainstay of venous ulcers. Lesions: multi-layer compression, bandage or stockings only after confirming good arterial supply. Check the ankle brachial index, and the ankle brachial index must be more than 0.9. Note: a normal ankle brachial index is ankle brachial pressure index is between 0.9 to 1.2, and values below 0.9 and values above 1.3 indicate arterial disease. And in this situation, compression therapy must be done carefully. Wound care: regular dressings to manage exudate and debridement of necrotic tissue if needed. Medications: topical or systemic antibiotics only if infected, and pain relief is important. Adjuncts like elevation of leg exercise to activate calf muscle pump, and skincare for surrounding eczema with emollients and mild steroids if needed. Definitive treatment of venous insufficiency is varicose vein surgery, endovenous ablation or sclerotherapy. Varicose vein surgery, endovenous ablation or sclerotherapy are definitive treatment of venous insufficiency. Prognosis: healing is slow. It takes weeks to months to heal, and high recurrence rate if venous insufficiency not corrected. Okay, this was a short explanation about the ulcers due to the venous insufficiency in a patient with a history of DVT. Thank you for your attention.